So this is a sponsored session, and we'll be speaking on BRAF mutated non-small cell lung cancer. And so the objective here is to understand the role of BRAF in metastatic non-small cell lung cancer, gain awareness on testing methods for the same, and let's look at the clinical data. And the clinical data would be a similar repetition of what Dr. Chakor has already presented. So I would uh, just touch at that. Now, whenever we talk about pathways, and this is for the exam going, there are only 3-4 pathways you are supposed to learn, and one of them is the KRAS, BRAF, MEK, and MAPK pathway. The other is the PIK3C AKT pathway. So for any drug, for any answer, you can just draw this diagram, and you would be correct in 80 to 90% of the times with this pathway analysis. Now, the interesting thing here is that in the MEK and MAP are in lower domains in the pathways, and it has been seen, and this was a good series of New England Journal publication which came between 2008 to 2012, and these were series of case reports in which in first they in squamous cell carcinoma of the skin they tried to block which had BRAF V600D, they only get BRAF inhibitors. What they saw was when they get only BRAF inhibitors, sorry, in melanoma they get only BRAF inhibitors. And when they gave BRAF inhibitors, they saw that there was an increased incidence of cutaneous squamous cell carcinomas. And when biopsied them, they saw that this was because of an higher expression of the MEK and the MAP kinase pathways. And hence they decided that not only it should be a RAF inhibitor, it should be a MEK inhibitor along with this. And thus the combination of RAF and MEK inhibitor was derived because it led to a higher response rates, and it also led to a decrease in one of very, I would say, a bad side effect, which was development of cutaneous squamous cell carcinomas. Now, when we look at BRAF mutations, and it says that only 1 to 4% of non-small cancers get it. I'm privy to the data which would be presented by Dr. Amit Ratan on the genomic landscapes of non-small cell lung cancers in India. In that, the rate is coming around 4.4%. So, the more and more NGS we are doing, we are going to find this mutation more. Now, when we talk about BRAF mutations, the key point here is none of the clinical factors you can predict it. Age, gender, smoking status, it does not predict, as neither is the histology pattern. What you could see that most of the times up till now the reports are in adenocarcinomas, but it may be time that you might also see that some people start showing that it benefits in squamous cell carcinomas. I do a lot of non-lung cancers, and I can tell you that there are certain histology in other types where you can predict that there would be BRAF. So like if you are looking at a GBM and it is specifically an epithelioid GBM, then there is a high chances that the epithelioid GBM will be having a BRAF V600D mutation. If you're looking at a thyroid cancer, especially if it's papillary or follicular, you would have as high as a chance of 60% that it would be having a BRAF V600D mutation, but such pathological correlates are not available in non-small cell lung cancer. The second thing is when you talk about BRAF mutation, we are specifically talking about BRAF V600D. If you see the ICD, the concentrations which are required for 50% of the death of the cells, these are lower only for V600E mutation. For V600X, like if it is A, B, C, or D, the drug doesn't act. And this is an important point to remember, because only in 50 to 70% of the cases it will be V600E. In less 30-40% cases, it would be the other partners, which can be a variety of other partners. So I think we would see in future is that apart from having dabrafenib, trametinib, we might see roles of coming of pan-BRAF inhibitors as they have started coming in pan-KRAS inhibitors. Now, is BRAF an independent prognostic? Obviously, we know that it predicts for the action of a BRAF inhibitor, but it's an independent. Is it an independent prognostic factor? And it does seem that patients who have BRAF mutation, they do badly, whether they are post-surgery or whether they are been treated with as a stage 4 treated with systemic chemotherapy. So this is one marker which is prognostic and predictive both, and if it is present and if you don't treat with the appropriate BRAF inhibitor, they certainly have a very poor prognosis with the median overall survival which is less than 10 months. Now, what happens in most of the situation is that BRAF V600D patients, because of these poor prognostic markers, approximately 1/3 of the patients remain untreated. Doublet chemotherapy is the most common treatment which you use in this, but the response rates are on the lower side. This is in the low in between 15 to 20%, and even the chances that the patient would live longer than 1 year are very small. So, how do you identify the patient as a BRAF mutation? Obviously, you need to have a broader profile for testing. If you test only for EGF and ALK, you are obviously not going to get a BRAF mutation. So, the BRAF should be there in your panel for testing, and most of your coupon NGS which have today do have this testing has been there. Now, it's important that we cannot rely on any factors to say that okay, BRAF, if the age is less, if it is female, it would be like that we would say that BRAF would be common. It's commonly seen that most of the time it is associated with adenocarcinomas. Now we have this combination has a dabrafenib, which is a RAF kinase inhibitor, and a trametinib, which is a MEK1 and MEK2 inhibitors. Both are reversible inhibitors. And if you see the IC50, the IC50 for BRAF V600 is 0.6 nano. As suppose for the MEK1 and MEK2 is also below 1. And if you look at the other types of BRAF, this is around 1.82. So the IC50 is very low for V600E. Now, this is approved, and it is approved by the DCGI to be used in patients with non-small cell BRAF V600E mutation. However, 2-3 months back, if I'm not mistaken, the BRAF has got tumor agnostic FDA approval, and any site where you have V600E mutation, you can actually use a BRAF inhibitor in that situation. So, we won't go to the rationale, we have already discussed this, and we'll come to the study which Chakur has given in quite bit details of cohort A, cohort B, and cohort C. So, if you see cohort A, only a RAF inhibitor was used. Cohort B is a pre-treated patients in which both a RAF inhibitor with a trametinib was used, and cohort C is patients who are treatment naive. The primary endpoint was overall response rate in the study, and you could see that smoking, no smoking, doesn't male female exactly similar. This is what the point I was making. You cannot have any morphological features or phenotype features which can help you to predict that there is a BRAF is there. Same way in the other cohorts also, there's hardly any morphological features. So this is something which you have to do the test for that. Remember that immunotherapy works well even in BRAF inhibitors. So just because the patient responded to immunotherapy doesn't mean that the patient may not have a BRAF V600E mutations. But it seems that up till now, the most of the research is concentrated in adenocarcinoma, except for a few cases of adenosquamous. It is not seen much in squamous. And this were the doses which were used in this study. And let's look at cohort A when the monotherapy was given. If you give monotherapy, you could see the response rate is only 33%. But in a heavily treated population also, when you give one combination, the response rate jumps up to 63%. That's what I was telling you, that when you block both BRAF and MEK, the response rate jumps and even the duration of response jumps. This is a group of 57 patients, and what is interesting here is this is a 63% response rate, but you could see count actually there are only 5 patients in which the disease size has increased. So less than 10% chance that if you, even in a pre-treated, heavily pre-treated population, you use a BRAF inhibitor, there's a less than 10% chance that the patient would have progressive disease as the best response rates. The duration of response is around 9 months, which is, I would say, at the best optimistic, because in many other TKI, in ALK and in NTLK, this duration of response is pretty longer than 15 to 18 months. And if you see, you would get a 6-month PFS around 65% when this combination has been used. Now, if you use an untreated patient, if you see that the response it still remains about 64%, so it doesn't matter actually for this drug whether you use in the first line setting or in the subsequent line setting, the response remains similar, and similar remains the duration of response. However, the chances of having progressive disease are much less when the patient has been treated in the first line setting. Now, this gives you a snapshot of what would happen if you treat with the monotherapy with the heavily treated population or in the treatment naive population, and you could see that if you treat with the monotherapy it is 33%. With the rest all the figures are nearly the same. So the message is that you need to use BRAF inhibitor whether in first line or second line setting. At present the data shows that it doesn't matter. I'll focus on one side effect here, and which is pertinent, is that many of these patients actually have pyrexia, and pyrexia is because of the RAF inhibition and not because of the MEK inhibition. So if the patient is having pyrexia, you need to stop the RAF molecule and not the MEK molecule. When this data came, I actually thought हाँ fever ही होता होगा, क्या होगा उससे ज़्यादा, but it is actually bad, and nearly 50% of your patients would have grade 3 and grade 4 fever, and patients get quite irritated because of this pyrexia. So the question is, how do we manage the pyrexia? If you have a temperature which is going above 38.5 degrees Celsius, stop the drug for some time. Give the patient antipyretics. Once it responds, you restart with that. If the patient is having recurrent pyrexias, then you can consider giving oral prednisolone. And mind you, this is required in around 10% of the patient, where you would have to give oral prednisolone. And this is a recurring event and a irritating phenomenon. So it's best that when you're starting the patient, you actually counsel the patient that this is going to happen, to that you would have here. This is the dose reduction in the way it goes: 150, 100, 75 and 50, and so is with the trametinib. Remember, if it is pyrexia, you need to only consider for interruption of the RAF, and the dose reduction restricts to RAF and not to trametinib, as opposed to if you have LFT derangements or anything else. With that, I would say thank you and sorry for extending the time.